Welcome everyone. Thank you for taking the time out of your busy diaries to join us for a webinar on a new resource that the LGA, Local Government Association, and SCIE have recently published called Achieving Integrated Care, 15 Best Practice Actions. And what we're going to do today is have a webinar that allows you to find out more about the resource and how you can use it in your local areas. But first of all, I'm just going to introduce ourselves. So I'm Ewan King. I'm Chief Operating Officer at Social Care Institute for Excellence, or SCIE, and I'm really pleased to be joined by Fiona Russell from the LGA. And hello. And Deborah Zansky, who's a Senior Associate of SCIE. And all of us three have been involved over the last year in developing this resource. So hopefully we can tell you, answer all your questions that you might have about the resource. So this is the plan. Steve, if we could have the next slide, please. Thank you. So this is the plan for the next hour. We're going to introduce our new joint resource that sets out what the evidence tells us works in achieving integrated care. We're going to describe its purpose, how to use it, and how we developed it. And then we're going to walk through the 15 best practice actions in a bit more depth and draw out some examples that we think you'll find helpful. And then we're going to leave as much time as possible for your questions, for your comments, and for your ideas. So I should have said at the beginning, we can see all of your questions, so do ask, keep the questions coming, the points of discussion, and we'll try to address as many of those as possible. What we will do is make sure that all of those questions and answers are made available along with the slides and the recording of the webinar a couple of days from now. So you'll all be able to see what we've said and what you've all said. So hopefully you'll find that helpful. Thanks, Steve. Okay, I'm going to hand over to Fiona.
Thank you, Ewan. So why does integrated care matter? Well, we could spend an hour, we could spend a week talking about why integrated care matters and coming up with the definitions and many forms that it's taken. So without trying to do that, but it's had many names, forms and objectives over the years. We've got integrated care systems, total place, care trust, integrated care pioneers, better care fund. We see how many years back we could go. We've also got many definitions. I think about the National Voices best definition using I and we statements, which hopefully all of us are familiar with. The NHS talks about triple integration, so it talks about health and social care, but it also talks about primary and specialist care, or integrating mental and physical health as well. But for me at the LGA, our definition of integration is guided by our vision called Shifting the Centre of Gravity, which is maybe a link we should actually provide at the end. And very much for that, the heart of that is about improving people's lives. It's not a means to an end. It's not about just doing it for the sake of doing it. It's very much about what does this do in order to help people have a better experience of care. It's absolutely about being centred on people's needs and their strengths, that it's so easy. We find so much with existing systems that services are organised around the service or the organisation, so it's about being organised around that person, then being right at the centre of the care, about it being delivered at their home or as close to their home as it can be, instead of always being dragged maybe towards the acute sector at times. It's very much focused on reducing, delaying or diverting need. That's a phrase that comes up a lot in the Care Act, but it means much more widely than that. It means about helping people to stay well and to stay independent for as long as they can at home within their communities. And it very much is about, so not only them having better experiences, but also about being able to allow the systems to better manage financial and demand pressures and hopefully create a better degree of sustainability. Moving on to the next slide. So why did we develop this resource? Well, maybe as the slide before I've just been saying, is that there's many examples of what integrated care looks like, but there's no one sort of size fits all, there's no one set of definitions. And so we very much wanted to try to look through the evidence and understand better how people have learnt, the things that people have learnt in systems, and how they have they've often improved the outcomes for people in their communities. We know that that success is often very variable, that there have been, people take steps forward, but then they can often take steps back, and that these successes are very, very hard won. And we know very much that it takes local ownership and collaborative leadership. And that it is very much about changing the behaviours and the mindsets of people who use services as well as people who deliver those services. And we know that there's lots of common barriers to overcome. We can talk about IT, about systems not talking to each other. We can talk about different regulations, different professions, different mindsets, cultures. There's many, many different forms that these barriers take. But we know that there are certain things that are critical to that success. And that's very much about ownership, leadership, behaviours, changing the way that we work with individuals at the centre of these services. So we wanted to try to understand where systems have done well and where they may be trailblazing and leading the way, but also for those who are struggling, and to understand what has been challenging for them and what they have learned along the way. So that was our intention in developing this resource. On to the next one. So what is its purpose? So it's to offer local leaders and those using and delivering care a really simple, practical list. We're not telling you anything, hopefully, that you've never seen before, but it's really about trying to bring that list together in a much simpler way, making it accessible so that you've got something that you can look at and draw from, rather than we've done the wading through the mountains of evidence, and Ewan and Deborah will tell you more about that in due course. So we very much want to be able to try to be able to draw that together so you've got a practical tool that you can use. It's very much about taking a whole systems approach. So it's not about one organisation looking at the services they're delivering, but it's about the coming together and talking about the services that you deliver and the outcomes that you want to achieve for the people that we serve. It's very much going back to the principles that we believe integrated care is about. It's about being person-centred. It's about being focused on the place that these services are being delivered and bringing all of those assets and services together to improve the lives of the people that we serve. We also, as well as hopefully giving you a tool that you can use, we also want to be able to use that consensus and show it up to national stakeholders, to the government and to NHS leadership, so that they can understand what are the actions that they can support in order to deliver integrated care policy. And that's me. Oh, no, it's not. On to the next slide. So how can you use this resource? Well, hopefully, as has been evident, this is about supporting your improvement. It's about continuous improvement. It is not in any shape or form performance management. That's something that we hope that it doesn't appear to be. Really, it's about facilitating a conversation, and that conversation can be in any shape or form that you want it to be, as long as it's across a wide range of partners. So in meetings or workshops, we find that that's worked well. We've been seeing it being used in terms of those areas thinking about integrated care systems developments. They're thinking about how do they take the next steps in line with things like the long-term plan, also the Better Care Fund. But it can also be used in a sort of slice of the system, such as commissioning frameworks. And the thing that we want to stress, and we'll be talking about this a bit more, is that there's no right order. There's no way or answer that you have to do in order to use this tool. It's simply a list of things that the evidence tells us works, and we want to share that with you and use it for you to use it to prompt your discussion and inquiry. We've got lots of top tips and practical examples, and Deborah and Ewan will point to these as we go through. But really, they're there for you to use as you want, to hopefully prompt you into thinking about how you can take the next steps in your integrated care journey.
Thank you. So back to me. So just to highlight that, clearly delivering integrated care is challenging and difficult, and both the LGA and SCIE have some well-developed offers that can help you make progress on integrated care.
Indeed, thanks, Ewan. We've got these things up on the slide there saying the various things that we both do. And one of the things we'll come back to at the end of this is that we're very happy to support areas who are interested in using this tool. In fact, actually, when we initially published it, an area got in touch with me and said, oh, we've used it as a self-assessment, which we were like, fantastic, that's exactly what we wanted it to be used for. So if that's an area that we can help you with, or a particular part of any one of the actions that you want to focus focused on, we very much can. We would look to be very happy to support those conversations.
Thank you. Right, Steve, next slide, please. So, how did we develop the resource? I think it's important to emphasize again that we wanted to create something that was practical, that was easy to use, easy to understand, easy to follow, and therefore it's important that we didn't produce a very dense academic document. There's nothing wrong with academic research. We've drawn on it to produce this resource, but we felt that it was important to develop this resource with those who will actually pick it up and use it. So we started by reviewing a range of evidence sources, and I'll come to those sources in a bit more detail shortly. So we undertook an extensive review of the literature, the evidence base, some of the evaluations that have been conducted recently into interventions and initiatives in this area. We brought all of that together, and from that evidence base we started to pull out what we thought were the key messages, the key actions that emerged from the evidence. We tested those actions out with a national steering group. We came back to that steering group on a number of occasions just to make sure we were on the right tracks. But then we also took those emerging actions to a group of people with lived experience and carers to get their views, to make sure to align with their thinking and what they feel is important. And finally, we took it to some fairly large workshops in both London and north of England to test out the views of commissioners, of practitioners, of social workers, of health professionals, and people in the voluntary and community sector to make sure it aligned with their thinking, what they feel is most important. Next slide, please. So, as I've said, we basically consolidated a broad range of key sector research. Two bits of research I'd like to highlight in particular. So for the Department of Health and Social Care, SCIE undertook a pretty comprehensive review of literature to inform what is called the SCIE Logic model. It's on our website. Do have a look at it if you would find that helpful. We also looked at the evidence that informed the Shifting the Centre of Gravity report, which LGA produced recently as well. And we brought that evidence together. As I've said, we tried to pool from that evidence, draw out key actions that the evidence suggests are likely to be beneficial to making progress on integration, and in fact accelerating our progress towards integration. So these are evidence-based actions that the evidence strongly recommends we deliver locally if we're going to make progress on integration. And you can see we also looked at the latest and most important policy and guidance documents to make sure that we're aligned with those as well. Thank you, Steve. It's important, I think, as well, when reading the document, that you're aware of some underpinning principles that I think are important to how the document is developed. First of all, integration is not the end goal in and of itself. I think that's an obvious point, but it can be missed sometimes. The outcomes are the most important element of what we're trying to drive towards. So all the way through the document, we're clear about how the evidence informs actions which in turn inform improved experiences and outcomes for those who use services. So to help us with that, we have linked explicitly actions to specific I and we statements. Fiona just mentioned those statements earlier. They are in the Think Local, Act Personal, Making It Real framework, and I think they're becoming very common currency across the health and social care system. And we think they're a useful way to try and locate the specific actions we recommend within the lives and experiences of those who actually use services. And finally, we believe that integration supports the building of community capacity for prevention, early intervention, and place-based care and support. And we use the phrase place throughout the document, but we are aware specifically that different local areas, different systems are going in different directions and define place in different ways. So when we talk about the concept of place, we are very aware that that means different things in different contexts. So those are just some principles that I think are worth bearing in mind. I'm now going to hand over to Deborah, who's going to take us through. Oh, sorry, just briefly, here are the resources that, some of the resources that I mentioned that we've drawn upon in developing our resource, this resource. So look at the LGA website, look at the SCIE website. There's plenty more to have a look at there. Thank you.
Yes, so these are the links to the document, both the interactive document online as well as a document you can download as a PDF, are available on the LGA and SCIE websites. So next slide, please. This is Deborah. Hello, everyone. I am going to run through the 15 key actions with a bit of explanation and go into detail on the LGA website with about 2 of them, just to give you a sense of what you can find and then how you might use them. We've had a couple interesting questions come through that I will incorporate into my remarks here. One of the ones that came up first was how the work that we've pulled together relates to what's called the 6 principles to achieve integrated care. And those can be found on the LGA website. These principles include collaborative leadership, subsidiarity, which is making decision-making as close to communities as possible, building on existing successful local arrangements, a person-centered and co-productive approach, a preventative, assets-based, and population health management approach, and achieving best value. And I think I can safely say that these are founding principles of what we've produced here. But the principles in and of themselves are not the actions. But what we are showing you today is consistent with those principles. Okay, so as Fiona was saying, what we've put together relates to actions that people can take at the front line of care, focusing on people and communities and professionals who are delivering care, and also at the place level, however it is defined or is best defined by local people, and then also across perhaps a wider system with leaders working collaboratively. The main objective is, why integrated care matters. And again, that is person-centered coordinated care. And that's what we suggest is the objective. In working with a number of partners locally, you may feel pressured into working on integrated care solutions as a way of diverting hospital admissions. We would argue that that's possibly the wrong focus. And indeed, we've had another question about our views on the Nuffield Trust report on why it's so difficult to evaluate integrated care. And that is really the conclusion that they came to, that if the evaluations are looking at whether integrated care is going to divert hospital admissions or other types of acute activity, that's asking perhaps the wrong question. So we would support the evaluation focusing on people's experience, whether or not it's supporting them to remain independent, staying well, whether the community services are wrapping around people to provide them with the right basket of services and support. So it's interesting that we can talk a bit more about that Nuffield Trust report later during the Q&A. The other thing that I wanted to mention is that what we've put forward here builds on people's own strengths and their agency. It's really important in the first action there around risk stratification that people who can most benefit from integrated care are identified. And one of the questions we've also had about risk stratification, just looking for my answer here, is the extent to which data sets can be integrated across health and social care to identify people. Now, we would argue also that it's not just data sets that can be used, but also a range of information, including qualitative data. So if you think about not just looking at who's known via statutory social care services or healthcare services, but also people in the community who might be deemed at risk. They might be frail older people or people with complex conditions and disabilities. It could be quite a range of people who would benefit from coordinated care, a wider range of services and support. So risk stratification is really important. Are you getting the services to the people who can most benefit from them? The second key action is about access to information. And this is where we feel it's really important for people to have, to be able to use their own resources and their own strengths, but they need support, they need information. It will help them in co-producing any kind of care planning, help them in any kind of care assessment. Access to information can be for individuals as well as their carers. The third thing on the list is multidisciplinary team training. Many places around the country have these multidisciplinary teams, or MDTs. That's all fine and good, but what we found from the evidence is the importance of having a sustained approach to developing the teams. And I'll get into some detail about that in a few moments.
Just to interrupt you there for a minute, Deborah, there's been a question there about whether we want to involve the voluntary community sector in this MDT training. I see we're all nodding furiously. Would you like to expand on that?
Sure. Who's involved in the MDT can vary from place to place. Local areas that are very forward-looking and inclusive, that have involved people, for example, from housing associations and other kinds of voluntary and community services, would probably be very welcome. It depends on the population, and it depends on whether that perspective is needed, but there's no reason to exclude the voluntary sector.
Absolutely not.
Personalized care plans is the fourth action. That's pretty self-explanatory, but what does that actually mean in practice? There's a lot of underlying good practice, and SCIE can provide you with a lot of information and support about that. But one of the things that's really important to stress here is what we're trying to suggest is a move from a reactive care system to one that is much more proactive. And that means involving people and their carers in care planning so that care is there to support people along the way and not always responding, especially to a crisis. However, as the fifth action here suggests, you do need to have community-based rapid response available. The best practices that we've seen through case studies both in this country and abroad have a single point of access. They make it simple for people to access the support and care they need, especially in a crisis. When we're talking about people who have complex needs, their care needs can actually deteriorate, or their care needs can increase as their needs deteriorate. So it's important to have those things in place. Next slide, please. I'm rambling on here. Okay, so in terms of the place-based care and support systems, we've identified another 5 key actions. Obviously, there are a lot of things that we could put into place-based systems, but these were the things that we found to matter the most in terms of progressing integrated care at a place level. What we're talking about here is how care is organized, how it's managed, and also how it's commissioned and paid for. Ultimately, it's about how organizations and the people who work within them can actually work across boundaries in a seamless way. That means commissioners and providers collaborating. The first key action is about having an operational framework that is aligned with the vision for the local area. Oftentimes we've seen some really good ambition from local areas, but when it comes to translating that vision into actual actions on the ground, there's a big gap. So that's why we've put that one first. Moving from a shared vision to a new local system requires collaboration and really getting into the tangible details. Related to that is integrated commissioning. So using commissioning helps, if you integrate the commissioning, it helps people access joined up health and social care resources more readily, especially the professionals who are coordinating the care. The third action is about shared records. We know that in many places, identifying and tackling the barriers to sharing digital care is still a problem. But it's absolutely essential. There's a movement working across health and local government, especially for people who have been identified as frail, getting their permission to share the records. And that's starting to, I think, crack the nut a bit more. But the most important thing here is to think about not using the absence of shared records as a barrier. And system leaders can really work collaboratively to address the myths around it, but also to make things happen. Community capacity is number 9, and what we mean by that is bringing together specialist health services, social care, and therapies to support urgent needs, not just in terms of post-acute discharge care, but also to keep people as independent and well as possible in the home before any kind of hospital admission. So it's not just about recovery and reablement or rehabilitation, it's also about keeping people well. Related to that is number 10, which is the partnership with the voluntary community and social enterprise sector. And that's expanding the thinking about community assets and how they can be brought to bear to support people who have long-term care needs. It's important for local government in particular to actively cultivate the partnerships so that the voluntary services, housing associations, and other organizations can also provide support to people in a proactive way. Okay. And last but not least are the 5 related to leading for integration. And these are points that I'm sure you've seen. They sometimes seem very common, but they are really essential in order for integration to happen. The central point is that system leaders make integration happen. They help establish what that common purpose or vision is for the community. And the more clarity there is, the better, and the agreement across the partners can support that. They also set an example. So the next one is collaborative cultures. They bring together, or the way system leaders work together can demonstrate to other parts of the system what collaboration can achieve. By creating a joint strategy for organizational development, for example, that could help develop mutual understanding at the place level and integrate ways of working at the front lines. The 13th point is resource allocation. This is probably the most difficult thing to achieve, but having a cross-sector agreement about which resources are available for delivering the integrated model of care is really important, and thinking broadly about what that means in terms of community assets as well. This will underpin the joint commissioning, but sometimes it's very difficult for partners to have that kind of transparent and honest conversation about the resources that are available. Accountability or governance across the system will assure that there's accountability for how the resources are allocated and what's achieved. And we can talk a little bit more also about the kinds of metrics that could be used for monitoring the progress towards integration as well as the ultimate outcomes. And finally, workforce planning. By leading system-wide workforce planning, that will support the delivery of integrated care. Place-based systems we know are working across the country to do this, but there are new types of workers that can support people who are receiving integrated packages of care, including in the health service called link workers, or you may have heard the term care navigators. Supporting the workforce needed for MDTs is also extremely important. Last thing I want to say about systems leaders is that one of the things that system leaders can do and can do well is remove the barriers that get in the way of progress, because there's a forum for leaders to be working together. Right. I'm going to take you through 2 examples in detail about what you can find when you look up the resource. So this is the first one around multidisciplinary team training, and I realize that you probably can't read the slide, but I will tell you what the content is, and then you can look it up. So what we've done here is identify the key action. We've also identified how to make it real with an I and we statement. That's the dark box in the top left corner. So in this case, the I statement is I have care and support that is coordinated and everyone works well together and with me. And the we statement is we work in partnership with others to make sure that all our services work seamlessly together from the perspective of the person accessing services. So for each action, we've identified I and we statements, and we think that's absolutely critical. And the people who were involved in our steering committee to pull this together from our co-production network were extremely supportive of doing this. Then we have an explanation about why this action is important. Why should you take this action? And so I won't read you the description here, but just so you know, the why is there. We've also identified who should lead and who should be involved. And then importantly, in that sort of green box there in the middle, we have how to achieve it. So what we've listed is, from the evidence, important steps that you could take locally to put this action into place. So for example, in this case, around MDT training, we talk about sustaining the investment in team development. Not just in what the teams are supposed to do, but having them work together as teams. We've included a list of topics that might be part of a joint training curriculum. We've also talked about how in much of the evidence, co-location of team members has been shown to enhance the ability of teams to communicate and collaborate. So it's based on the review of evidence about emerging good practice as well, and indeed some feedback from the field. And then next to that, alongside the green box, we have evidence and tools, and we've included links. This is just a small sample of things that we found useful and that others have suggested that we use. And then in the right-hand column, we have examples of good practice as case studies. And then in the bottom right corner, we have actually included a definition of multidisciplinary teams for those who aren't sure what they are. It was suggested that we have a glossary, so we've included the definitions alongside the actions themselves. So something like this could be used, as Fiona was describing, as sort of a, not really like a checklist, but certainly as a self-assessment tool for local areas. If you have MDTs, who's leading them? Who's involved with them? Have you thought carefully about who should be involved with them? And indeed, how are you training them and what kind of support are you using? So, yes, I think I've got this here. We've had a question about the kinds of topics that could be included in joint training, and I'll read you what we've got here. This is not necessarily an exhaustive list, but this is the kind of thing that we've pulled out of the evidence. The first is standardized approaches for joint assessment, care planning, care coordination, care management, and crisis response. So that's thinking about the whole pathway of care and having standardized approaches, starting with joint assessment, that can be used by multidisciplinary teams in a local place. The second is making the shift from reactive to proactive and preventive care. So that's thinking again about, in the care plan, what if something were to go wrong? What if care needs increase? What if the person's situation deteriorates? And planning for that, involving the person and the person's carer as well. The third is about working with shared care records and information sharing. SCIE has done some research with the social care workforce about their ability to work with shared care records, and has found that there's a great need for additional training, and part of that is becoming familiar with using care records. But in addition to that, it's also what needs to be part of a care record and what can be useful in terms of communicating with other members of the team. So joint training on how to work with care records, and so they're not just a place where you deposit information, but that it's actually seen as a communication tool, is something that we recommend. A fourth one is understanding and accessing the resources available for personal care plans, including personal budgets. So joint training can enable progression towards personalization and the use of personal budgets. What else? There's a couple other things around improving relationships and behaviors, as well as how to work with link workers or care navigators to support self-care and social prescribing. So there's quite a bit here.
Just say there's been a question there about the role of the care navigators and care coordinators being critical, which you would absolutely agree with. One of the things that we've found is that it's not about just seeing that as a post, but actually seeing that as a role that every member of a multidisciplinary team has a part to play in care coordination and care navigation. That there's something about if they take the call, so to speak, they follow it through, so you're responsible for looking after that person and bringing in whoever is required, rather than it being passing over to somebody who is opposed to do that.
We've had more questions here.
Lots of questions.
Did you want to answer
one?
Yeah.
Well, so one of the other questions is about whether MDTs have to be based physically in the same space. I mean, the research suggests that does help to be co-located, but equally, given the austerity, and I think the question alluded to the fact that there's so much pressure on social care in particular that it's very hard to have social workers permanently based in these teams, that you approach it from a more networked approach. So you have an MDT as almost a network, and we have seen that work quite well. So Islington, for example, has MDTs through a more virtual network approach, and in fact there's a case study on SCIE's website about that. So there are different approaches to MDTs, and increasingly use of virtual MDTs is growing as a way of working.
And just to come back to the point about the care navigation being seen as a post by the NHS, and also there was a question earlier about whether the fact that social prescribing is now a mandated sort of service or description, and whether that's a step backwards. There's obviously the risk that that can be seen as the case, but it's also an opportunity. The fact is that there is funding being put into these services. It is also the fact that primary care networks are being given a far more preventative focus and required to do that, and required to work in a multidisciplinary way. In fact, they can actually contract with the voluntary sector. It means working at those partnerships even more, doesn't it? Mm-hmm. So that you take advantage of the opportunities rather than it being a threat to existing services, which is undoubtedly a risk. But it's about making the best out of what one can.
Yes, and in this time of more limited resources, I think the solution is about different partners collaborating, whether it's at the network level for primary care, involving social care and housing and other services, or whether it's at a place level.
But exactly, and very much the fact that there's been a lot of care navigators and around, been parts of multidisciplinary locality teams for many years, and that is a small pool, and whether it's about sort of robbing Peter to pay Paul is one of the challenges. But it has to be about, therefore, taking advantage of that and trying to build up the services that these care navigators are working with as well, because there's no point in having care navigators if they don't have a wide range of community assets that they can draw on and help to develop.
Okay. We also had a question about how the MDT model works with community mental health teams. Well, the answer is that they do. The question about how can be dependent on the local area. And we would certainly advocate for as broad a range of services to be available to people, and community mental health teams would be part of any kind of service arrangement. So depending on the needs of individuals as they're being assessed, the involvement of a representative from the community mental health team would be crucial. Let's take a person, for example, with dementia who might still be living at home. I think that's probably a good example of where you'd want to have involvement from the community mental health team.
Great.
We're going to be picking up another question that we had around integrated commissioning and any good examples that exist. We saw one of the answers from one of those listening in being Plymouth, which I absolutely agree. They've got a really good citywide approach, which goes way beyond health and social care, which I think is a really good example. Another long-standing example is North East Lincolnshire. They've been doing work around their Section 75 for many years, and it has led them to think about integrating their delivery as well. So it's a very good example to look out for. And there's plenty of examples across the Greater Manchester locality that each of the individual areas, Tameside, have done a lot of it. So is Salford,
yeah.
They're out, again, it's taking a very place-based approach to how they can bring their commissioning together. Maybe sometimes it is that, I know in Salford that the local authority has taken the lead commissioning for adult social care, whereas the CCG might take the lead commissioner for other areas. So there's a good number of examples there, but I think the key is always about going beyond health and social care, isn't it, and focusing on place.
Exactly, and that's really the point of my next slide, which is the other example I was going to share. I don't think I'll go into too many details here, but the reason I've selected this is because of what Fiona was saying. If there's another thing that you can take away today is to think beyond just statutory services. And the partnership with the voluntary and community and social enterprise sector is part of the solution to supporting people to stay independent and well. So like the other example on MDTs, you'll see the structure is essentially the same here. We've got the why take this action, who should lead and who should be involved, how to achieve it with a list of things here, which I know it's difficult for you to read, but happy to go through it. And then some links to evidence and tools, as well as some case studies. And again, essentially how we make it real with the I and we statements. Commissioners should be working to develop these partnerships locally. It is the opportunity, I think, to work also with health partners, because there is an imperative to focus on prevention and early intervention in the health service. So there's an intersection of interests here, but it's going to take leadership, especially at the place level, and it's going to take quite a while, I think, to build up the capacity outside of statutory services and to integrate them into the delivery system, especially for people who could really benefit from integrated care. And then I think we're at the Q&A. There are other questions.
Okay, so just a couple of, thank you, Fiona and Deborah, thank you very much. So just a couple of questions that I want to make sure I pick up on. So Bianca from Malta, my goodness, I wish I was in Malta right now. She has asked whether, which sectors has this tool, this resource being tested in, and really we hope it's with the whole of the health and social care sector, including primary care, including mental health, including social care, but importantly housing and the wider voluntary sector. So I hope you can see from the examples that we're thinking very broadly about the definition of integrated care.
And very much in developing the resource, that we held a number of workshops with a wide range of practitioners from around the country, as well as then taking the finalised list and going back out into systems and asking them how they could use it. And we have already had one system where they have used it as a self-assessment tool, and found it a positive experience as well, which was good. So we hope also that this is really the beginning of the journey of this document, and very much that we want to hear your ideas about what we can include and how we can develop it. It's an ongoing experience.
So another issue, absolutely, we recognise is the lack of funding going into the voluntary sector. That is a barrier, we agree. I think it's absolutely crucial that when we are commissioning services, that the voluntary sector is brought into the conversation at an earliest possible stage, so they become part of the commissioning process and actually receive a greater share of the resources, particularly around prevention. But actually the voluntary sector is not providing free services that the NHS and local authorities can't pick up. It is providing excellent quality services that need to be invested in. So we absolutely agree with the sentiment, and involving the voluntary sector in commissioning and planning is crucial.
Just picking up a question there that's come in about good integration starting with a robust set of joint principles and outcomes. I completely and utterly agree with that, and that goes back to one of the beginning questions we had around what is the value in integrating data. And for me, that's the biggest value. It's about having a single version of the truth that every partner, every person at all levels of the system can get behind. Having a legally binding document, in many ways that is supportive, but I know that One Croydon Alliance took a long time to get there, and they found that it had advantages and also disadvantages. I can think of other systems where they've done the anything but legal option, and it's been much more about the sort of working together and working around any existing sort of organisational forms. So I think it very much comes down to what works for you is what works for you, and there's definitely no one size sort of fits all. But what I do think is very true, and it's in the document, is common purpose, and that is by far the most important thing. And that's stories as well as data, as Deborah was saying at the beginning. That's by far the most important starting point.
And one of the reasons there are a lot of differences is that collaboration is based on strong relationships. Yeah. And those relationships will differ in different places because different people are involved. But
it's outcomes that help you form those relationships, because if you're working around an individual rather than the pressures that we all have from our own organisations of the targets that we need to meet, they're all, they help to fragment us and separate us. But coming around to make somebody have a better life, that is something that we can all agree on and we can all sort of collaborate on.
So there's a question from Jeff about the role of primary care providers, GPs, district nurses in this agenda. Anyone like to come in on that?
Well, sure. I think certainly the advent of what's now being called primary care networks, in other places it's a broader range of community services that are going to be developed on a neighborhood basis, for example, would necessarily involve GPs, district nurses, if you can find them, and other types of health professionals. But our point is that it's not just health professionals alone. There are certainly a lot of objectives or expectations, rather, for primary care networks. And in order to achieve those objectives, collaboration at the neighborhood level will be absolutely essential. And we see the MDT still fitting into that model. It's tried and tested. There's a lot of good experience around the country. There's no reason to reinvent the wheel on this. And they can be part of what's within the primary care network. In some places, the PCNs will be GP-led. In other places, they'll be on a much more collaborative leadership model. It's emerging in different ways. But fundamentally, I guess if there's a good focus on providing well-coordinated care, especially to people with complex needs, and thinking broadly about what care and support can be brought to bear to support that person to stay independent or as well as possible, then that will bring together the services. So start from people.
And just picking up another question about thoughts on risk and benefit shares, they're absolutely essential. But one of the things I've certainly seen with the areas we've supported is that people jump to them. They think that if we just get a risk share in place, then everything's going to be okay. And that certainly has not been the case. And there's been many attempts at capitated budgets and all sorts of things.
I don't think we're there yet.
No, we're not there yet. But what you do see, it's about building up the trust so that you can let go and that you can have some sort of, is a much more looser and informal arrangements, and they definitely are the basis. And we've seen some of them through the Better Care Fund, and that feels like a good development in many ways. That it's about starting to share, isn't it? Rather than going, we need to have a cap and collar arrangement, and it needs to be in place within a year with a shadow budget. That just, from all the experience that I've seen over the last sort of 5-10 years, that has not been the way to success. It's much more about building up trust and relationships.
Yeah, it might bring people to the table, but it won't actually resolve things.
It doesn't, because it's always about mindset and collaboration.
Exactly.
And that's what has to come first before any legal arrangements. Otherwise, the legal arrangements drive something rather than it being the collaboration, which is what has to drive integrated care.
Yes, and the bringing together of commissioning can help. I mean, we do know that there are struggles to bring together the timetables around commissioning, but they're not necessarily impossible to overcome. And again, it boils down to the relationships.
Exactly, because if you don't have relationships around integrated care, then people start doing parallel commissioning. You start pulling things out instead of actually moving forward.
Okay, so we're coming to the end of our time on this webinar. Any last minute questions? Please make them easy. No, seriously, just any last questions, do just send them in now. There's one about prevention there.
Yes.
Would someone like to, Deborah, would you like to take the one on prevention?
I think that's a really interesting question. Should we look at prevention of health and care needs, preventing so early in a person's life due to lifestyle issues? I think the answer is yes. I think from the perspective of local government, there would be affirmative, and as well as from the health system.
And it ranges from taking a public health approach, which then is by far the sort of primary prevention. But then I think a lot of the work that we're doing in integrated care is much more about secondary prevention, isn't it? Where there may be some early signs of sort of pre-diabetes, in that sense of that there are certain indicators that diabetes is a risk, so then taking action to address those lifestyle factors and improve somebody's health and well-being so that they don't go on to develop diabetes, as opposed to the public health approach of such as stopping smoking and so on.
Right, population health.
Exactly.
Okay, so it's great when someone answers one of the questions for us, which is great. So someone asked a question about social enterprises. I'm sure there are many good examples, particularly around areas like social prescribing at the moment and care coordination. I know there are some really good social enterprises entering that space, and someone's pointed out a website that you could go to have a look at that. So thank you.
Just to add the point about finances and funding, use of information, shared data underpinning it all, I could not agree more. But then that comes first, and in time it becomes to finances. Sorry.
Brilliant on that. Rather good point. We'd like to draw this to a close. As I've said earlier, we will make the slides and the recording available very, very soon. So watch out for that. It'll be on our Twitter feed. It will be on eventually in our bulletin. So do look out for that. And thank you very much for your time. Thank you.
Thank you for your wonderful questions.
Thank you, and use the resource and let us know how you're getting on.
Brilliant. Thank you.
Thank you.